So, good afternoon, everybody. We've reached the fag end of the AIOS. I mean, it's been spectacular to see how so many halls have been managed so efficiently through a virtual conference. I think congratulations to all the organizers. And I'd like to welcome all my participants and panelists to this Diabetic Eye Masterclass. I think this is a very important session. Very important so because we have with us Dr. Rajiv Kovil, who's a diabetologist, and we have an eminent panel of nationally renowned retina specialists. Given we'll have, the way we have dressed it up is this session will have first a half an hour of, there'll be a question answer session with Dr. Rajiv Kovil and Dr. Mona Bende taking those questions. And after that, we'll have three talks by three eminent speakers, Dr. Ajay Arora, who will be talking on lessons learned from my roadblock cases. And then we will have Dr. Dinesh Talwar talking on winds of change in PDR management, 12 minutes each, all of them. And Dr. Rupak Biswas will talk on my feel good case in PDR. So it's my pleasure to first of all introduce my faculty for today. Dr. Rajiv Kovil is a practicing diabetologist and founder of the Kovil's Diabetes Care Center, was awarded the FRCP Edinburgh. In addition to practicing at Andheri and his Lokhandwala centers, he is an honorary diabetologist at several leading hospitals in Mumbai, with Nanavati Super Specialty Hospital, Raheja Hospital, KLS Hospital, etc. And he's a founder member of the United Diabetes Forum, a non-profit association of practicing diabetologists in India. Also served as invited faculty for diabetology fellowship program at D.Y. Patil University. On the editorial board of Diabetes Today, member of the National Editorial Board, Heart Care Journal, has been an organizing secretary and very active at all annual scientific events. Very passionate about Project Blue Dot. And this is he was the chief coordinator for this. It's a UDF initiative where the primary aim was to identify and mark diabetes-friendly foods with a blue dot after defining the blue dot based on parameters like glycemic index, glycemic load, total calories. She's a notable and well sought after speaker at several national and international conferences and has been an honorary chief guest for National Wellness Nutrition
Thank you, sir.
Awards. So it's a pleasure to have you, Dr.
So
Rajiv Kovil. It's wonderful to interface with an eminent diabetologist like you.
Thank you.
And I'm looking forward to our interactions. Also on this Q&A session is somebody who really needs no introduction, Dr. Mona Bende, a renowned retina specialist, known nationally and internationally. She is deputy director and a leading retina specialist at Shankar Nethralaya, eminent center in Chennai, India. And it's my pleasure to have her on this meeting too. And we also have Dr. Ajay Arora, who is a very senior retina specialist in Delhi, with his fellowship from Shankar Nethralaya, and is known so much more for his innovations. I mean, he's got a slew of innovations, surgical and medical, in retina, and it's always refreshing to hear from him. Dr. Dinesh Talwar was a senior professor at AIMS for many, many years and is now leading practitioner in Delhi with the Center for Sight. His insightful commentaries, his questions are legendary. I mean, we always look forward to having him. He always brings a fresh mindset to different problems, and a person with a very challenging, who has an inquisitive bent of mind. Dr. Rupak Biswas from Calcutta, welcome, a close friend, and did his training from Shankar Nethralaya and is in one of the leading retina centers in Calcutta VBI Hospital. He's a wonderful surgeon, another surgical innovator, and it's always wonderful to listen to him. So welcome, Rupak. So with this, we'll just get kick-started onto our session. I'll, start off with a few questions. So the first would be to Dr. Rajiv Kovil. So Dr. Rajiv, while addressing, the metaphorical elephant in the room in diabetes management, we always talk about the macrovascular. The attention seems to be more on cardiovascular issues. But have we been guilty of overlooking, microvascular complications in diabetes management? So, Dr. Rajiv.
I would say yes, because over the years, diabetes and macrovascular disease has been right at the forefront. And UKPDS, which was one of the most well done epidemiological study, told us that 1% A1C reduction could cause a 25% reduction in microvascular events. But it left it open for macrovascular events, which we as physicians are concerned about: the stroke, the MI, the heart failure, and everything. But in the last 10 to 12 years, there's been a 360-degree change in the management. Earlier, we were like cowboys. We would go down to as low HbA1c as possible, use whatever, but get the HbA1c down. Now, after the cardiovascular outcome trial, it's very similar to the protocol S in your, where there's been a change in management. Since the cardiovascular outcome trials have come into being in the metabolic space, we have been targeting a lot of comorbid conditions using anti-diabetic drugs. So whether it's heart failure, whether it's stroke, whether it's hospitalization due to heart failure, cardiovascular death, non-fatal stroke, non-fatal MI. So there has been a change in terms of a holistic approach towards diabetes management. And I would say that microvascular has been neglected, and there needs to be a huge effort, because when you have large studies coming out which focuses on heart failure and cardiovascular death, the small rat which causes more problems is somehow forgotten in terms of the bigger elephant sitting in front of you. And that's the problem which we are facing, that the morbidity due to eye, foot, and the kidney is very high, but the amount of data we are generating is quite high for the macrovascular events, and there seems to be that hurdle in our mind space right now.
Thank you, Dr. Rajiv. Wonderful to hear insights on that. So, over to you, Dr. Munna. So, while there is a focus on cardiovascular, issues and renal complications in diabetes, do you think the focus on diabetic retinopathy has been adequate, or do you think it needs, special mention, special effort in the management algorithms also?
Actually, before I was asked to take part in this session, I thought that yes, maybe it's ignored. But I think if you look at the ICMR guidelines for management of diabetes, diabetic retinopathy is there. It's right in the beginning, it's in the summary, and it's very prominent throughout. So I think it makes screening mandatory for all diabetics. Now the only issue is how the screening has to be done, who will do it, and I think that's probably we'll go through that later. But I think it's not been ignored. Like Dr. Koval said, it may be when you have large data about death, then morbidity sometimes goes a little lower. Unless at some point in time you look at the connection, like you say a severe diabetic retinopathy, what is the risk of death? Then maybe there will be some connect. But right now probably it's morbidity versus mortality, which is why we get that impression.
Thank you, Dr. Munna. So, Dr. Rajiv, now as an expert in diabetes, uh, from a physician's point of view, are the microvascular complications easier to manage compared to the macrovascular? And what is the evidence and your experience so far?
Uh, in a diabetic, it's always difficult to manage, because a person with diabetes is a confused soul, and he comes to you with symptoms, and majority of the time the science is something which he doesn't understand. So if you weigh the two, microvascular complications is easier to manage, because there you have to consider only the HbA1c reduction, because blood sugar control and microvascular complications have a linear relationship. But if you look at macrovascular complications, there are the whole metabolic abnormalities drive the cardiovascular disease and the chronic kidney disease and the foot infections and all those things. So there you need a complete holistic management. So microvascular is easier to manage, but in our country, patients with diabetes are the ones who want it's like an ATM approach. They want to come in and go out fast. They want to use the least possible medications, have the least interface with doctors, have the least possible interventions, do not want to check up at home, do not want hypoglycemia, but pay the least amount of money but get the best results. So in that terms, our system doesn't support a good structured care, and that is what we actually require. We have almost 80 million diabetics, and we require a good structured care to prevent progression of both micro as well as macrovascular complications.
Thank you. Fantastic. So, Dr. Muna, what are the knowledge gaps, if any, you feel, in the management of diabetic retinopathy today? And do you think there's any delay, there's an inertia in early referral, and how can we, improve this and address this?
I think knowledge gaps are not there. It's the relative importance and the balance between your support systems and accessibility. I'm sure everybody knows it's important, but in a country like India, we are looking at relative importance. So, every diabetic to be screened, or every person with blood sugar more than 200 should be screened. Those are things. Now, the issue is who is going to screen. In a busy government hospital, do you have the support systems? Does a small private practitioner in a small town have access to someone who can evaluate the retina? Whereas chances are there are physicians everywhere, but is there a trained ophthalmologist who can examine the retina, who does it as a routine? Those are issues that are more
Yeah,
important. I don't think
probably,
there's a knowledge gap,
yeah,
it's the implementation of the
probably the
program.
accessibility to care and awareness.
Accessibility,
Yeah, yeah, yeah.
yes. And
So,
varying guidelines as to who
absolutely
is to screen, how do you screen. That's more
correct. Yeah, yeah. So, Dr. Rajiv, while changing track now to a little more about therapy, while intensive therapy has its advantages in preventing complications, hypoglycemia is one of the dreaded complications of very intense management itself. So now, while newer agents have helped us overcome this to some extent, do you think some agents still used for rapid intensification can cause a very dangerous level of hypoglycemia? And then how clinically dangerous would you say this whole issue about hypoglycemia is?
No, hypoglycemia is an issue. The hypoglycemic related admissions almost equal the hyperglycemic admissions globally in the last 10 years. Hypoglycemia is a huge rate limiting step in retargeting a very good control and patient chasing an intensive control. Hypoglycemia has been a huge risk marker for all kinds of cardiovascular events and all cause mortality. In a study almost a decade back called as the VADT study, hypoglycemia was only second to the event, to the occurrence of the event. So it is a huge risk marker. Now, whether it's a risk factor, we still require prospective randomized control trial. A risk factor, I mean that smoking is a risk factor for cardiovascular disease, but hypoglycemia is not a risk factor, but it's a risk marker. It surely identifies individuals who are vulnerable to all cause death. And whether it's so if you have a patient with severe hypoglycemia, he's vulnerable to complications, and he requires a lot more interest, a lot more amount of investigation, because there's something going wrong. He may be having chronic liver disease, maybe having chronic kidney disease, maybe he's a hypothyroid, maybe his insulin regimens need to change. So hypoglycemia should be an alarm bell which kind of strikes in the doctor's mind that I need to investigate this person more. He's vulnerable to a lot of things, and we need, and today we have a lot of therapy which we call it as insulinotropic drugs, which doesn't work when the sugar is low, and so it's kind of a little bit of a smart drugs, and the sugars won't drop, and that gives us a lot of confidence using it, especially in people staying alone, in elderlies, in people with chronic kidney disease who are at very high risk for hypoglycemia. And hypoglycemia, iatrogenic hypoglycemia, can actually deter a patient to chase good sugar control. So today's management is focused on, one, prevention of long-term complications, but second and most importantly, improving the quality of life of the patient. And hypoglycemia is a huge rate limiting step. We have to prevent hypoglycemia if we want to handhold the patient to a good outcome, and that's extremely important.
Thank you, Rajiv, Dr. Rajiv. Fantastic answer, man. That really is an issue. So, Dr. Muna, have you noticed hypoglycemia having any major adverse outcomes in the eye as well?
I don't think hypoglycemia itself has adverse outcomes, though rapid reduction of blood sugar is known to cause transient worsening of retinopathy. But hypoglycemia per se, acute hypoglycemia, is more likely to cause neurological manifestations than changes in the eye. And yes, frequent fluctuations can transiently change the refractive error. But I think just an acute hypoglycemia by itself, we may not be seeing much in the eye.
True, true. Thank you. So, Dr. Rajiv, from the diabetes front, what can be done to facilitate, earlier management, earlier detection of diabetic retinopathy?
I think it's awareness, 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 education, education, education. Nothing else can help. But importantly, if you look at gestational diabetes, for example, or chronic kidney disease in patients with diabetes, for example, or breast tumors, for example, if you have a easier screening tool, diagnosis is better. So chronic kidney disease, we have a dipstick test. Patient just passes urine, we do a dipstick, and we see albumin is there. Then we working up further from chronic kidney disease. All gynecologists, obstetricians, their antenna is on that if you have a pregnant lady at first antenatal visit, do an oral glucose tolerance, and we are able to pick a lot of gestational diabetes and reduce morbidity related to gestational diabetes. Similarly, a lot of breast cancers have come in because patients have been taught to do some amount of breast examination, and a lot of health checkups include mammograms and mammographies as a part of the package. And this education that eye is extremely important, and 75% of blindness could be related to retinopathy in patients with diabetes, is something which is not communicated, or there's no shared decision making with the patient and the doctor, and that needs to be there. And that once this comes in, I think if the screening tools are easier, accessible, available, cheaper, I think a lot more retinal disease will be picked up earlier, and we will have lesser morbidity related to diabetes eye disease, surely.
Yeah, I think absolutely right, and I think perhaps this is where artificial intelligence and neural network screening might really help. Pick up early
True.
cases.
True, true.
So, Dr. Muna, as a retina specialist, what are your expectations from physicians, endocrinologists, diabetologists in terms of referral and management of retinopathy as such?
Yeah, I think probably the only thing, once patient can't see, then reference is fast. I think the fact that you can have very severe retinopathy in the presence of good vision or normal vision and no visual complaints. So when they see a diabetic, either they examine the retina or have a connect with someone who will do it. You have whatever method of screening is available and emphasize to the patient that there may be sight-threatening retinopathy where vision is normal. I think that is probably what needs to be conveyed. You don't have to lose vision to have
Correct.
retinopathy.
More of proactive treatment,
Yes, that's the
proactive
way.
referral. Yeah.
I think in most places, at least in Chennai and all, it's being done. Probably
Yes,
this needs to dissipate into smaller towns and
absolutely, absolutely.
cities.
So now questions for both of you. Maybe Dr. Rajiv can first take the same question, and then Dr. Muna. So what is the role of a multi-specialty team unit, in diabetes management? What are the expectations of each specialty to, kind of foster holistic diabetes management for all our patients? So Dr. Rajiv, yourself
So
first.
I started with it that a
Correct.
diabetes patient has his whole signs and symptoms, and he needs to be managed holistically. We can't compartmentalize him, and that is something that actually in a good tertiary care hospital it can happen, but in a private setup it doesn't happen. And any screening which you tell a patient to do in chronic care, he considers it as an expenditure rather than an investment. So to make sure that he considers it as an investment, there needs to be a lot of education being done, and that itself will kind of uplift him to another level, graduate him to a level that can help us. So when you tell him go to a kidney specialist, go to a retinal specialist, go to a cardiologist, he raises eyebrows, you know. And but if we can, if at every encounter with patients we can do that, then the multifactorial approach will surely do well, because I believe that a patient with diabetes requires psychotherapy also, requires nutritionist also, a diabetes educator, a retinal specialist, a kidney specialist. All these people need to be in the multifactorial team. And this effort itself, where somebody from the metabolic space is speaking at a national event of the All India Ophthalmic Society, is giving meaningful dialogue to any outreach programs which we in the metabolic space do, or the All India Ophthalmic Society do, needs to be done together, so that the reach is far better. And that is what a multifactorial approach, because the end benefit is the patient, and the patient cannot be an ophthalmologist patient or a diabetologist patient. Patient is a patient, and if you treat
Absolutely.
him that way, he gets benefit from all the front.
Yeah. Dr. Muna, your thoughts?
Yeah, well said. I would say the more practical approach would be to have the screening where the diabetologist is, because it
Right.
eliminates the need for one more visit. Because when we talk about intravitreal injections, bilateral intravitreal every month, we forget sometimes that the patient has other problems also. These
Absolutely.
patients
Right.
need an attendant, these patients may be working. So, on a practical point, I think even if we had to do this, we would not be able to do.
Absolutely. Absolutely.
My
We're kind of
concern,
guilty of,
yes,
putting patients in silos, and,
yes.
forgetting
So
that they need to.
yeah, I would think if the screening is done when the patient sees the diabetologist, rather than a retina specialist needing to screen outside somewhere, then
Right.
the chances are that screening will
Right.
happen is more likely.
So, a related question again, to what can be an effective communicating model for diabetic retinopathy awareness amongst healthcare providers, diabetologists, and general ophthalmologists? So I think it is somewhat a similar kind of a question. Dr. Rajiv?
If I could go first, I
Yeah.
think that a simple screening. I know the fundal cameras cost anywhere from 1.5 to 2 lakhs of rupees. Now, if you could have something cheaper, one, if you could use a lot of kind of apps which are there in the smartphones, and I use one of them, the Peak Acuity app at my clinic. Do I have a fundal camera? So it just screens a patient, puts him at a level that I may be having an eye disease, and then I go and do the fundal examination. So there needs to be something to do, and if this can be done at across, it can really help. Our national association is starting a campaign called Defeat Diabetes, where we are looking at 10,000 doctors across India, trying to, in the next 100 days, check blood sugars of every person who enters or comes at an interface with a healthcare worker. So whether he comes to an ophthalmologist or an orthopedic or a gynecologist or a skin specialist, he gets his sugar done. That is our motto for the next 100 days, starting 1st of July. Similarly, we can have a lot more screening being done for the retina before the fund, because fundus fundal camera in metros, tier 1, tier 2 cities you can have, but the other places is not possible for doctors to invest. There's no ROI on that. But if we can have a simpler tool where doctors can screen and then send them to an ophthalmologist, I think that could be a far better way of screening.
Right. Dr. Muna, a
I,
quick comment on
yeah,
that?
I think there are some smartphone fundal cameras as well, but diagnosing diabetic retinopathy through a poorly dilated non-mydriatic pupil, sometimes you're likely to miss things, and generally it's not recommended that a non-ophthalmologist or a professional as far as eye care is concerned should dilate the pupil. So that is also one of the recommendations, that unless there is someone trained in eye care there, pupil should not be dilated, because
Yeah.
patient can develop some other problems as well.
True. True.
So I think we need to get that part taken care of. Telemedicine is there. There are many outreach programs now. I'm sure Arvind has them.
Yeah.
And yeah, I know CMC Vellore runs a very active
Yes.
outreach program. So I think we are reaching there. Probably that initial inertia, if the patient also has to.
Yeah. Wonderful. Absolutely. So I
outside,
think outreach is really critical, in
yeah.
this effort. So final question, and I request quick, crisp answers to this. Which are the simple, practical, and non-imaging based solutions for primary care providers for triaging patients with diabetes for screening? So Dr. Raju,
I,
yourself
I,
first.
I think there is a connect between diabetic kidney disease and diabetic retinopathy. So ACR is what we do for most of our patients, and we do it 6 monthly. ACR positive patients surely go on to do a fundal camera. On examination, we do a fundal, sorry, on first visit, we do, and annually we also do. But I think using apps in the phones to actually look at how people can do some amount of visual acuity testing at home can actually trigger them to go to eye specialists earlier. And
Sure.
that is something that we need to teach, that probably children, people at home, if they are taught simple things about visual acuity, which are there in a lot of apps. I don't know how, whether they are approved or not, I'm not gone into that, but it at least helps them in terms of a little health literacy about the eye. And once that comes into being, patients will graduate to going to doctors to seek opinions early. So I think there needs to be something there to make sure that they are approaching doctors with the eye problems earlier.
Absolutely. Dr. Munna, your take on that?
Yeah, I would think that imaging is, especially because we know a lot of diabetic retinopathy doesn't have a visual problem. I think
Sure.
it's a little difficult to get out of the imaging part. Now, whether you examine the retina or you photograph the retina, I think imaging is there to stay in whatever form, however simple we can get it. But there are guidelines, even if you look at the NPCB guidelines, ICMR guidelines, even if there's no visible retinopathy in a non-mydriatic camera, and the patient cannot see beyond 612, they have to go and see an ophthalmologist. So I think that is one guideline that is there. So I think that needs to be done. And just
Sure.
one more, Anand, if I may.
Sure, please.
Probably what we are also looking at, and I'm sure most people on this panel are looking at, is, when do we say yes, this diabetes, this 200 micrograms, 200 is that the cutoff for surgery? I think all of us want to know, is there a number or is it patient to patient? Where does HbA1c come and where does the blood sugar level come?
So,
So,
for
so,
you,
so,
Dr. Rajiv.
so the
Yes, I think.
diagnosis of diabetes at an HbA1c of 6.5 is derived from retinopathy itself. So it's retinopathy derived HbA1c. Now, for now we would say HbA1c below 7% for all elective surgeries, but that may not be the case. So if your fasting is anywhere between 80 to 130 and your PP is less than 180, you can go in for surgery. And if suppose if I have a patient with 400 also and he requires a primary bypass, I will not tell him you wait for 24 hours. It all depends from patient to patient. But elective or semi-emergency, we would require a postprandial less than 180 and then fasting between 80 to 130. That is right to go. And now we also have a newer concept called as glycemic variability, where you can pick up using what we call as continuous glucose monitoring system. And if we can have 70% of those values in range, then the patient is good enough to go in for any elective surgeries.
Thank you.
I think
Fantastic,
that's great,
Dr.
Anand.
Rajiv. I think we are
Thank you so
bang on
much.
time to finish the session. Dr. Ajay Arora, you have a quick comment to make?
Yeah, I had a question for Dr. Rajiv, and I think what Dr. Muna asked is actually a burning question because All India Ophthalmic Society has categorized the random blood sugar as 200. And if it is more than 200, theoretically, it can become a medical legal issue. Is that really true?
It's not really true, Dr. Arora, that that 200 is an arbitrary figure based on, again, retinopathy derived postprandial levels. Now if 200, now we all know that blood sugar is a very labile thing. You can have one day a 200 and next day it could be 120. So it all depends on the glycemic index of the food and the type of food. So just based on one value, one should not be. It would be ideal to tell the patient to do a structured monitoring at home, okay, a pre-meal and post-meal for 3 to 5 days, see what the mean blood sugar is. And if you see all the time it's higher, then he needs a change in
So
treatment
this
and
is,
then going for surgery.
yeah, this is particularly for the surgery. Whatever surgery we do, we want to have a control. So there was a study which was done by the British Journal of Anesthesia and Orthopedics, and they found that whether they operated at a sugar level of 242 versus sugar level below 200, it really did not make any difference. So when we have an emergency, so therefore somebody in this country has to come out with a statement that, look, it doesn't really matter.
I
Having one value of 200 and postponing surgery is ridiculous.
absolutely, I
No,
completely
so
agree, and
you people should do it.
we echo that thoughts. I don't
No,
think
it's not, it has to get into print mode, sir.
it is it I don't think any emergency surgery should ever be postponed because of sugar values, unless the patient is in ketoacidosis and some form of hypoxemic state.
That I,
Anand, I want to
Yeah.
clarify this. I want a
Yeah.
little clarification. See, this is how actually we are getting into trouble, because when you say emergency surgery should not be postponed. Now, is an intravitreal injection for diabetic macular edema an emergency or not? Technically, it is not. It can wait for a month. But the fact is that patients are not going to be controlled for 2 months, 3 months. Should we deny him then the right to get an intravitreal injection? It's not happening anywhere else in the world. We have to have some guidelines on this topic. It is
the
not just
DRC, yeah.
retinal
DRC,
detachment. Is that an emergency or is it a
I
semi-emergency?
completely agree with you, Dr. Talwar, that this is a semi-emergency. Patient will lose his eyesight, and that is what I said, that we should do a structured monitoring for that patient, and patient at whatever level of blood sugar can be brought to your level of control within 3 to 5 days. It is not. It is very easy to control sugars, to be very frank.
So in
Right.
drca.net,
So
they do not bother about sugar levels. They have injected in various studies up to
yes.
11.7 of HbA1c, that is 297 milligram percent
True.
level, and they've injected, and they don't even check blood sugar.
So I think that we have to take it up in a joint, AIOS and
I wish we could do that.
I wish we
diabetic.
could do that, Dr. Rajendran.
Yeah,
It's
absolutely.
a
I
topic
think
which
it's
has a lot of
critical.
relevance in practice.
I think what both Dr. Ajay and Dr. Dinesh have brought up are very valid points. I think we should examine that from an AIOS perspective. But I'll take this opportunity to thank Dr. Rajiv
Thank you so
for
much.
fantastic answers, and it's been very enlightening to listen to you, and
Thank
you've
you
been
very
very articulate and very fluent. And thank you so much for sharing time with us on a Sunday afternoon.
Thank you.
So
My
thank
pleasure.
you.
My pleasure.
We look forward to
Thanks.
further interactions with you.
Thank you so much.
Okay.
Thank you.
Thank you. If you could stay around, we'd love it. Otherwise, have a great day.
Thank you so much.
Thank
you
you.
very much.
Thank you. Thank
Thank
you.
you.
So now we'll move on to the didactic session. It's my pleasure to call upon Dr. Ajay Arora and invite him to talk to us on lessons learned from my roadblock cases. And we'll probably have this for 12 minutes so that we have 3 minutes of discussion at the end.
I was told 15 minutes, but anyway, I'll try to hurry up.
Let's see. I know you're a young gazelle. You can run through it.
Yeah. Let me try. I hope it is.
Could you screen share?
Yeah, I'm trying. Is this visible?
Yes, it's visible. Full screen.
Yeah. Can you see it? And
Yes.
am I audible? Fine.
Yeah,
So,
fine.
lessons learned from my roadblock cases. Okay. And that's the disclaimer. So this is a patient who had come to me. This is many years back. This is a story which is in 2008. So all the modern surgical techniques and modern drugs and all were not available. We did have Lucentis, but other things were not available. This patient was a 64 years female who was diabetic for 16 years, thalassemia minor, well controlled metabolically. She had blurred vision in both eyes. He had NPDR with macular edema, had undergone multiple injections of Avastin and supplements tripod. And she had come to me, and her son was a major criminal lawyer. So when she came to me, this was the picture, and we at that time had an optoview OCT, no angio-OCT for those days. But anyway, she had thickened both right and left macula with spongy and cystic macular edema, no vitromacular traction. And I decided that I would go ahead and give Lucentis. Patient had not received Lucentis before. So we gave her Lucentis, but actually it did not make too much of a difference. And then we started trying to understand. So this patient was well controlled metabolically, but her hemoglobin was 9.8 and did not increase. I consulted the physician and he told us that the patient has to live with this hemoglobin, and the hemoglobin can vary anything from about 8 to 9.8. She has never gone beyond 9.8. So we know that thalassemias are the commonest single gene disorders. They are autosomal recessive. They can cause defects in the color vision, abnormal dark adaptation. They can produce an isolated cataractous changes. And she did not have any of these things. She did not have increased vessel tortuosity or a picture which is related to thalassemia, which is a pseudoxanthoma elasticum, a picture with angioid streaks and leopard skin appearance, blue orange. But the patient had macular edema and blurred vision. That was the only feature of this thing which we thought was diabetic macular edema. She did not even have, she had not got any transfusions. She had not been put on any chelating agents, obviously because the hemoglobin is not high, and physicians were unwilling to give her any blood transfusion. Now we know that supplemental oxygen improves diabetic macular edema. So we discussed with her whether you would have nasal oxygen connected every day at house so that you could increase your blood oxygen level. But she refused. She said, no, I can't do that. You do whatever you want, but I'm not going to sit at home and have oxygen going into me. So please remember, this is almost 11 years back. I was working as a lone practitioner, not being guided by any institutional backing. I looked up the literature and talked to many retina friends from across the globe. People were that time not sure that vitrectomy could be done in a non-tractional case for diabetic macular edema. Patient had already received subtin on steroids, so there was no point injecting too many steroids, and the only option was to give an IVTA. But well, I asked myself, is there traction? So there was, or is the ERM, is the PVD, how is the ILM, is there significant ischemia, how is the peripheral retina? So these are the questions which I wanted to ask, and I found that there was no demonstrable traction on the OCT clinically. There was no epithetic membrane, and there was no PVD, obviously. ILM did not appear to be thickened, at least in the OCT, and peripheral ischemia was not there. We went to the literature, and it's been shown that if this was in animal eyes where one eye is vitrectomized and the other eye is not vitrectomized, and branch venous occlusion is created in one eye. In both the eyes, the eye where the branch venous occlusion is created in the vitrectomized eyes does better than the eye which has got vitreous in it. So whenever we do a vitrectomy, we know that there are fluid currents, which means they bring in oxygen from the periphery to the area which is ischemic. So this is what happens, either because of laser or because of vitrectomy, you end up having more oxygen supplied to the macular area. And since there was no demonstrable ischemia, additional laser was ruled out. We talked to the patient's family and decided to go in for a vitrectomy. So this is what happened after vitrectomy. Her macular thickness decreased dramatically. It was less by about 200 odd microns, and we operated the other eye. Her visual acuity improved in the right eye from 6/60 to 6/24, in the left eye from 6/36 to 6/18. And she has now been on intermittent follow-up. Right now, she's in the US. The whole family has actually become connected with us as family friends. Right now, she's in the US, and I have not seen her for a few years. But whenever I get a chance, I will probably like to do an annual for her. So here is there was another patient who was a 60 years old male, diabetic for 10 years, hypertensive, blurred vision. Patient had CKD, splenomegaly. On examination, patient had pancytopenia, was worked up for bone marrow. There was hypercellular, gastroduodenoscopy was done, malaria antigen and Kala-Azar antibody was done because they wanted to find out why the patient has lowered hemoglobin. This was the picture. Patient had a macular edema, had been lasered, uh, underwent cataract surgery in the center, and had received multiple injections of intravitreal eccentrics. So the patient would respond to eccentrics, and subsequently, what happened was that there came a point where patient said that I can't keep on having injections. We could not do any additional laser. So we had an option. I discussed with the physician whether a splenectomy is indicated or a renal transplant is indicated. We lost the patient for follow-up for a little while, but eventually patient underwent a renal transplant. He came back to us, and since last 8 years, patient has not required an intravitreal. Oh, sorry, eccentric for any antiviral. So the spleen size had reduced, the anemia had improved, macula became flat, and did not require any additional anti-VEGF. So the take home from both these cases is that anemia must be treated in any case of macular edema. Vitrectomy helps in macular oxygenation even in a non-tractional diabetic macular edema without IL-8, and one can judiciously use anti-VEGF and other parameters need to be handled. Right? Now, this is a convention. This is a case which I wanted to share because of the COVID times. We know that we have been bothered about COVID with intravitreal injections, and the question is, does it really matter if the injection is delayed in a diabetic patient? So here is a female who had a visual acuity of 6/12. She came to us in Jan 2020. This is a clinical picture, the angio-OCT done on 21st of January. And on 1st February, she received intravitreal eccentrics in the left eye. This is the picture of the left eye before and after visual acuity had improved 6/6 post-injection when she came to us on the 6th of February 2020. After that, COVID came in, the patient was not able to come and she did not come to us for 6 months. But the patient was communicating on the phone. Patient had maintained a good metabolic control. So this is the right eye when the patient came back to us this was on 6th February, where the patient came back to us in August. The visual acuity had deteriorated. You can see the OCT here, the macular edema had increased, the cystic spaces present here. In the left eye also, the visual acuity had reduced from 6/6 to 6/12 parts. So almost 6 months had passed away. But then we talked to the patient and decided that we will go ahead and inject. And so the patient underwent intravitreal injections at different periods of time. This was on 17th of October. After the injection, patient's visual acuity had improved. Then subsequently in March, patient received the 4th intravitreal injection, March 2021. And then after that injection, went ahead with the cataract surgery. And now in April, she is not in a follow-up. This is what the OCT is. And she's doing well. The visual acuity is 6. And same thing happened in the left eye, where again, after the 4th intravitreal injection, she had a cataract surgery in the left eye. And again in April 2021. So both eyes did well, though there was a gap of almost about 6-7 months because of COVID. Despite that, in diabetes, even if there's a little delay because of the COVID situation, the problems related to the diabetic macular edema are not so significant that they are side effects. This is so this is another patient who presented. There's a 61 years male, type 1 diabetic. He had a hemoglobin A1C of 20, oh sorry, 10, and this is the picture. It's very difficult to interpret this macula, but patient received 3 injections of monthly Adherence. Visual acuity improved to 612. And then the patient was lost for follow-up, came back after 6 months. Metabolic control was okay. The hemoglobin A1C was 8.6. Otherwise was metabolically stable. But we got a wide field angiography done, and the patient had this picture had been lasered before. So this patient underwent additional PRP. Subsequent to this, the edema became stable, visual acuity was 6/9, and has been followed up with no further injection. So basically, the take home from this was that we must not only look at the diabetic macular edema, look at the periphery. In case additional laser is required, that should be lasered. Otherwise, we'll keep injecting these patients who actually would benefit from additional interventions done to the periphery. For this, the white field angiography. Okay, so I just finished the last thing. So this is a 58-year-old obese female who was diabetic for 18 years, who was taking lasered, also glaucomatous, had received intravitreal injections, both Avastin, Lucentis, and subsequent Ozurdex. This is the picture in the right eye, this is the picture in the left eye, and this is, she came to us when Ozurdex was not available. So she has all the biomarkers of the OCT suggesting that she would need a steroid, but she is glaucomatous and Ozurdex is not available. And so what next? Should we give an IVT? No, because she's glaucomatous, the pressures are going to go up. Subrenal strikeout, again the pressures are going to go up. Should we do a vitrectomy? I'm not sure. So membrane is there, and clear-side biomedical suprachoroidal transplant is not available. So we went ahead, and I'll just show you what I did. This is a small device which I have made for suprachoroidal injection of transplant, where the 30 gauge needle is used. Transplant is injected into the suprachoroidal space. Usually for initial patients, we were actually measuring the scleral thickness and deciding where to inject. So this is the picture. This is pre-SKITA, suprachoroidal injection of transplant. This was my 14th day, 34th day, and 70th day. Similarly, in the left eye sheet as well. So this is the comparison, and this is overall the picture of the patient is pretty well. Thank you for your kind attention. I hope I have not overshot my time too much.
Thank you, Dr. Ajay. I mean, lovely cases, very challenging cases, all of them, especially the ones, the initial two, the one with the thalassemia and the patient with the transplant. So it's not easy to, it is a brave call to take, do that, surgery. And we do know that, oxygenation can help the macular edema reduction. So since we are almost out of time, I'll request Dr. Dinesh Talwar to please straight away go on to your talk. We'll, if time permits, have a little more discussion on all these wonderful cases at the end. Dr. Dinesh Talwar on winds of change in PDR management for 12 minutes, if possible, please.
So, yeah. So can you see my screen?
Yeah. Seeing your screen. Yeah. Full screen, please. Yeah.
Okay. So this is my disclaimer, and so let's come to this. Why, basically there has been a paradigm shift based on this understanding of the role of angiogenesis in the development of proliferative diabetic retinopathy. We all know angiogenesis, the development of new vessels originating from pre-existing ones, but these are abnormal vessels. And these growth factors activate the receptors on the endothelial cells. And once activated, the endothelial cells release proteases, degrade the basement membrane, finally allow these endothelial cells to leave the original periparental wall, and then they proliferate and cause tube formations and cause these abnormal abnormal vessels to form. And the pivotal thing in this whole thing is the vascular endothelial growth factor, which is both a specific endothelial mitogen as well as a vascular permeability factor. Note that. The important thing is that it can account for both proliferative and vasopermeability changes in the course of PDR. Now, we already know that there are high levels of VEGF in patients with established PDR, and they get normalized with laser photocoagulation. We also know that you can prevent the development of a proliferative stage in mice models of ischemic retinopathy by blocking the VEGF action. And then finally, we do know that if you inject VEGF, you can cause iris neovascularization in primates. See, the important thing is that intravitreal injection of VEGF in primate eyes can actually cause intraretinal hemorrhages, retinal edema, venous bleeding, microaneurysms. Now, this is important because this is the basis of this can be used as the basis of our explanation of diabetic retinopathy regression following anti-VEGF agents. So this is important to keep a note of, right? So now, is PDR really as much of an issue as we are trying to make it out to be? Well, the fact is that if you look at it, though diabetic macular edema is 5 times more common than PDR-related blindness, but what DME causes is moderate vision loss, and what PDR causes is severe vision loss. And the number of cases is not less, almost 17 million, as opposed to 20 million of DME. So we have huge number of cases that need to be tackled. What is the current technique? The current technique is PRP. We all know that, and it works very well by reducing oxygen requirement. And that causes destruction of highly metabolic outer retinal cells, improves the retinal oxygenation from the choroidal circulation, and decreases the VEGF production due to the destruction of the hypoxic cells. So all three together work together. Now, if it's so good, then why are we looking for alternatives? Then the fact is that we know PRP can cause a decrease in visual acuity because of macular occurrence, macular edema occurring or worsening, can cause peripheral vision loss, sometimes rarely cause effusions, and it is painful. Most importantly, supplemental laser treatment could be needed again, and you could have disease progression requiring vitrectomy despite adequate treatment in around 5% of patients. So the protocol S actually evaluated the effectiveness of ranibizumab compared to PRP in patients with PDR. In this one group of patients was randomized to receive ranibizumab monthly for 3 injections. At month 4, they were evaluated again to see whether the neovascularization had recovered. And if it was still present, additional injections were given. And then at month 6, if onwards, injections were given as required. And if no neovascularization was there, it was not given. Or if it had reached a stable level, then also no injections were given. Now, what did we get in the protocol S? What we got was that there were better visual outcomes, less visual field loss, most important, fewer vitrectomies, and lesser development of center involving DME in the ranibizumab group. What was the advantage of PRP? It wasn't without advantages. Fewer visits, fewer injections, greater cost effectiveness, especially in eyes without DME. But more than half the patients in the PRP group needed supplemental laser during the first 2 years of surgery. The other important thing was the mild difference also in the chance of worsening, which was slightly more in the PRP-treated eyes as compared to ranibizumab. At 5 years, the results were similar. The visual results were not different. The difference in patients who had no DME at baseline, there was actually no difference in visual acuity also. And that mean changes in visual acuity in patients with DME Now, in those group, there was initial better results that disappeared in 5 years. Visual preservation, the initial greater difference began to decrease at 2 years, and by 5 years, it was much lesser. But there was a very big concern, and that is of the number of patients lost to follow-up. 1/3 of the patients were lost to follow-up, and despite the inherent destructive nature of PRP, the patients reported more or less similar outcomes. Now, what is more important? In patients without DME, 7 injections were required in the first year and 10 in 2 years. In patients who had DME, 9 injections in the first year, 14 in the first 2 years. And as opposed to that, now patients who had PRP along with the injections, 5 injections in the first year, 9 in the second year. Now, to my mind, it seems to me that PRP may actually decrease the need for anti-VEGF treatment in the presence of concomitant DME. So the main advantage, it seems to be in the peripheral field peripheral field preservation. However, even this, there's actually been a study from UK which said 88% of patients who had a PRP could pass the driving test with adequate binocular vision fields. So it's not such a big issue either. The main difference, it seems, is in the lower rates of development of DME in the ranibizumab group compared to PRP in eyes which had no DME at baseline. And you can see that difference is 22% versus 38% even at 5 years. The other important was that many of these patients improved over time in terms of the diabetic retinopathy stage. So you can see the improvement in 2 representative cases from ETDRS score of 71 to 35 in this case, and from 71 to 35 again in this case. So basically, you could have an improvement in the stage of diabetic. Complications were more in the PRP group, and that's what was surprising to me. The number of cases requiring vitrectomy were much higher, 15% versus 4% in the ranibizumab group. So, but the basic fear, there is a danger of poor treatment adherence to anti-VEGF treatment in patients in a study in which 13 eyes of 12 patients who had their treatment interrupted for around 12 months. They came back with vitreous hemorrhage, neovascular glaucoma, and traction detachment, and more than 50% of the eyes ended up with visual acuity of hand movement or worse. So you don't want that stage to come. So this is maybe the way to go, where PRP was compared with a combination of PRP with anti-VEGF, and there was significantly higher regression. At least 2 major studies have shown that, and then the Proteus study, which compared PRP plus ranibizumab to PRP in high-risk eyes, again showed a similar thing. So what you get is that if you do combination therapy, you probably get a better result than if you do just a PRP alone. The other, so somebody may say, well, why PRP versus combination? Why not monotherapy versus combination? So that was also done, and basically in the PRIDE study, what it showed was that at month 3, the regression was 66% in the ranibizumab group. It had not regressed in the PRP group, but again, it had regressed in the combination group. But if you see, at 12 months, again, the regression, some of the patients had got their neovascularization back in the ranibizumab group, much less in the combination group, and very little in the PRP group. The final lessons we got from the PRIDE study was you can get a recurrence following monotherapy. Laser may be a better choice for high-risk PDR, and the combined therapy seemed to give the most sustained results. So now, the important thing is This is for regression, but we're now looking for a stage beyond. Can we actually cause a regression of diabetic retinopathy? So people have now evaluated what happens to the diabetic retinopathy severity scale. And this has converted the initial 85 levels to 13 different levels of the DRSS score. And is it possible for us now to turn this entire clock back? Well, let's see. Yeah, so sorry. So when you review the Rise and Ride study, that was found that a two-step change in the DRSS score at 2 years could happen was there in 36% of ranibizumab addicted eyes. And this was best in the eyes at the highest risk of progression to PDR, that is severe, very severe in PDR. This change was maximum. So it seems that maybe we can do something. The Vivid and Vista trials again showed something similar, that you could regress diabetic retinopathy. Protocol T also showed that this could be achieved with all anti-VEGF agents. And finally, the Panorama study also showed a two-step improvement. There they used aflibercept and showed that 66 to 79% of patients had a two-step improvement in the DRSS scores at week 52. So while this can happen, there's a little precaution to be kept. While the regression occurs, but the FA does not change the amount of non-perfusion. So therefore, I still believe the best option would be combined anti-VEGF therapy with PRP in the periphery. So how do we manage PDR cases? How would I like to manage them? If it's raised neovascularization, complete laser therapy. First, give anti-VEGF injections. If it's a flat neovascularization, I just need half a minute. If it's a flat neovascularization, anti-VEGF followed by laser soon after. And if you have neovascularization persistent after adequate laser, you can have VEGF inhibitors. What about the role of monotherapy? I'm not going to discuss these individual cases and just tell you now what we believe about monotherapy. I believe monotherapy is something that we should only do after counseling the patient about the need for 14 injections or more in 2 years, with the possibility of more later, need for regular follow-up without a break, and the risk of retinal traction detachment requiring surgery if you do not do a regular follow-up. It's like catching a tiger by the tail. You've caught it, never leave it. You don't leave it, you're safe. You leave it and you may end up in trouble. Thank you. Of course, in a patient like this, anti-VEGF treatment as monotherapy would be contraindicated. So ladies and gentlemen, I conclude by saying anti-VEGF therapies for PDR has a definite role. This judicious use is required, and it's not still clear the risk of how much is the risk of neovascularization in raised neovascular forms if you treat them with monotherapy. Thank you very much.
Thank you, Dr. Dinesh. I mean, that was a fantastic talk. I mean, I love the interpretations you made, especially from the PRIDE study. I think they are very valid and very important in the context of our population. So, I mean, since we're running out of time, I'll request our friend Dr. Rupak to we'll go to his talk immediately, and then at the end, if you have time, we will take up a lot of questions. Let's hope we have time. So, Dr. Rupak, could you load up your feel-good cases in PDR?
I think a lot of enlightenment talk by Dr. Talwar, and as usual, when Sir says, so our job becomes much easier, and then this is what I was expected to talk about, my feel-good cases. So I'll actually will stand on Sir's shoulder, and then I'll show a few of the cases, and which I was just thinking whether Sir knows my cases earlier also, and accordingly he has given his talk. So maybe is exactly what Sir has told. I have a few cases to share with you. So whenever you have a feel-good cases, before that, let me share with you a feel-bad cases. So this is a 56-year-old lady who presented to me just last year, pre-COVID lockdown period, and she was I have advised, considering this condition, she has a poor control, glycemic control. So we have, I thought that I'll do this PRP. You can see the fresh PRP marks, and then we have advised her for giving anti-VEGF injection, because you have a flat proliferation. There is no traction as such. So, but again, she has to go back, and then she, due to lockdown, she got stuck and could not come. 3 months later, when she can come to me, is this. So when you have a macular traction and this kind of proliferation has progressed, and had a in between she had a COVID, and she has a progression of this disease. So it is a total, and at this point of time, it is very difficult. Already traction retinal detachment has started. So we have added some more amount of the laser to the periphery and advised for surgery. But again, glycemic control was not good at that point of time. Could not do anything. She went back and again stuck and came back another 3 months later. This is the situation. So this time there was no other option other than the going ahead for the surgery. We finished surgery, and she is having 636 vision, starting from 612, 618 vision. So this is how we have, over a period of time, we have, this is the gradual, progression of the disease, which actually could have prevented by combining at the initial phase. So this is how in one frame you can see how the progression of the disease has occurred. This is the other eye. I could, when she has come for the second time, I saw that there is similar kind of thing is in the other eye. So I have given the injection in this eye, and she is enjoying vision in that eye, in spite of not very tight control of the blood sugar level. So this is a good case for showing a feel-good case, as well as a good case to show the comparison of both the eyes. So I'll put to my case 2. This is already Pascal laser has been done in one case, and we did fluorescent angiography, and this case was showing there's multiple areas of leaking, both superiorly, inferiorly. So there was a presence of significant neovascularization even after laser treatment also. So we thought that yes, there are some skip areas in between, so we can put additional laser. But before that, if we can combine with anti-VEGF, and that's what has been initiated. And then you can see there is a lot of regression of those initial phases, and then you can very precisely add up laser in these areas. So that's what we have done, and this patient was doing very well. This is a case 3, when again a patient who is have a lot of peripheral CNP areas, along with there is a neovascularization, and there are significant amount of the leaking microaneurysm in the posterior pole. And so we have planned for the combined treatment, initially giving anti-VEGF, and that this is the result after the anti-VEGF treatment, and this is what has been planned for the laser treatment. Another similar case, but here you have this patient is having PDR. Along with this patient is a patient had multiple myeloma. So I mean both combining PDR along with the diabetic retinopathy, proliferative diabetic retinopathy, and the in presence of multiple myeloma, the chance of progression of the PDR becomes very faster. And as you can see, there is a vaso-occlusive phenomenon, are very particular and very precise compared to the other diabetic areas, and they have a focal areas of CNP areas as well, and very discrete margin. So this patient combined with anti-VEGF, and then planned for taken up for the you can see significant amount of the resolution of macular edema as well, and this patient has been taken up for laser photocoagulation. So the clear-cut advantage, what Sir has told earlier also, the clear-cut advantage what we get from a combined treatment is that it takes care of both PDR and DME at the same platform. So initially, if you can reduce the VEGF load significantly, that prevents worsening of the DME after PRP also. So you have you are getting significant amount of the window period by which, and anytime you can top up with anti-VEGF injection over the period of time whenever some neovascularization is appearing. And the chance of, which is one of the important part, where sometimes we do face even after in a frank PRP, PDR cases, if you do PRP, there is a chance of vitreous hemorrhage in those kind of cases. That chance also regresses if you do and give anti-VEGF injection and then start doing PRP after 2 weeks, 3 weeks later, so that the aggressive neovascularization goes down. And you get a window period, especially when the diabetic control is not very good control. So by this way, I'll just, I have shown few of my cases where I have combined treatment along with laser and anti-VEGF in case of DME, in case of PDR, or PDR with GME. Thank you.
Rupak, I mean, fantastic cases. Those were not cases that are easy to manage. I think, I mean, pertaining to what you have shown and Dr. Talwar has also talked about, I think a lot of us actually do in our real world practice do combine, anti-VEGF and injectable, and lasers in the, the management of disease. Most of the time, very often, especially people with poorly controlled diabetes, you get a lot of these kind of cases. And on top of that, there's juxtaposed systemic problems where, you have a hyperviscous, hematologic scenario, then you could get this sludging effect. And I think we're seeing more of that in this COVID period, so that's what. So if I might ask, Dr. Dinesh Talwar to respond to Rupak's cases, especially the third case and the first case, if you could add your thoughts.
Yeah. So in the first case, I have a little issue, and I want to ask you, how would if you see the left eye also, there is at the disc there was a fibrous front going superiorly, right? And that would scare me a little bit. After watching you and seeing the response, I may be more convinced about doing that in the presence of a little bit of traction. What I want to ask you is that if you see raised neovascularization, you see flat neovascularization, not an issue. If you see raised neovascularization, then would you like to give the anti-VEGF agent? And if you don't mind, can I show you just one case? I think the slide is there, just to show you the case in that situation, already lasered. Would you like to give an anti-VEGF? May I show you the?
Yeah, I mean, we get the idea. Yeah, if you can show, let's show. Yeah. Meanwhile, can I ask Dr. Muna, madam, if you're here, if you could, just respond to this scenario which Dr. Talwar is putting up. First of all, thank you very much for those fantastic, answers that you gave. Thank you.
Okay. So you see this on the nasal side, there's a TRD. You see this? This entire
yes, in the lower panel. Okay.
Yes, in the the lower fundus photograph, lower fundus photograph, left eye. Yes. So this whole thing. Sorry, this is the right eye, but this is the nasal side.
Okay. I was looking at angiogram.
Angiogram also. The whole angiogram shows temporally also and nasally also. It's a raised front. The nasal thing is also got a TRD with.
Correct.
Right now in this situation, and already lasered.
Correct.
Yeah. So what would you do? Would you like to give an anti-VEGF?
Sir, the temporal one, I believe this is a very flat one, isn't it, sir?
Yes. So around that we lasered.
Yeah. So we have a significant laser has already been done. So if we, I would like to depress in the periphery and do some amount of the laser. But again, if I am prepared for taking up this case if needed for surgery, then I can plan for anti-VEGF as well, because this temporal will definitely regress with anti-VEGF, but there is a chance of progression of that nasal part. But being in the nasal part, so I am little on the safer side.
Yes.
So
vision.
Yes, but again, I should explain to the patient that if needed, we may need to undergo surgical intervention to preserve your vision.
Yeah. If the same thing was on the temporal side, then what would you do?
Probably I'll wait and observe and do some amount of the laser treatment and wait and see whether it is progressing or not.
Yes. Because this is the area which I have a concern, and I don't know, Anand, if you've been doing the injection for these cases.
So that's what. So I think one important thing when you mentioned about elevated traction is the location. It's not just whether it's flat or elevated, it's also where this elevated is. So if it's on the nasal side, you're safe. On the temporal side, not so. But in the nasal side, the issue is if you don't do any laser or take proactive action, what's going to happen? It may bleed. That's the first and most important thing. If the patient bleeds, you can go ahead, do a vitrectomy, and you can get away with putting in gas. Whereas if it, becomes, if it's a temporal side and you let it be, it can, knock off the macula. Putting an injection, if it's a nasal elevated attraction with DME, then I might go in for, an injection with a little more margin of safety. So that's my, take on this. Dr. Muna, would you like to
temporal
comment?
one, you would wait, is it?
Which one? Sorry?
In the temporal side, you would wait.
Temporal side, I would really look hard to see if I can put in some more laser, because with laser, I can titrate it. With an injection, I cannot.
Yeah. So I think this is the message, that if you have raised neoaspiration in a difficult area, be careful.
Yes.
Mona, would you like to say something?
Yes, a very nice case, and your fluorescein angiogram also shows us there is a lot of area in the periphery probably that is untreated. And I would agree with Rupak that I would probably do a peripheral laser, because there doesn't look like any traction at the posterior pole. I wouldn't worry too much about the nasal prolif right now. I would worry if I was planning an injection. Since I'm not planning injection, I wouldn't worry about that nasal proliferation at all. I would just add on more laser.
Okay.
Yeah, and one more point I just wanted to highlight here, sir, regarding the raised, like Dr. Anand was telling, the location. So if a nasal TRD, which is very just juxtapapillary nasal TRD, and a TRD which is near the arcade, either superior or inferior arcade, that area is little vulnerable to develop a combined retinal detachment much faster than a nasal one. So if you have already a very good traction with a lot of proliferation is there and which is attached, so this is another just an observation, sir.
Yeah, exactly. So to Dr. Ajay Arora's presentation, question for Dr. Muna and Dr. Dinesh. Refractory diabetic macular edema, you've done everything. The macular edema is continuously coming up. When do you consider vitrectomy for a refractory diabetic macular edema? If you do, if that is there in your option palette at all?
I would need another excuse to do it. I have done it, but I would need another excuse, like an ERM also existing in that area, maybe contributing to then I would go ahead and remove the ERM.
Without traction, you would not, even if a patient is, vision is deteriorating.
Some form of pure.
I'm giving you the worst case scenario of a non-tractional macular edema. You've given about dozen injections, your patient has been compliant, you've given aflibercept, and the vision is going down. You can see the ELM going.
Yes, so if the vision is less than 624, I would give it a chance.
You would try. Dr. Mona, madam, your take?
In the absence of traction, I would still be hesitant. I'd probably look and see what was the best vision the patient ever had. And now we know if we have a good coordination, patients with CML, patients with thalassemia, patients with anemia, if we can get that handled medically, probably we can.
So I'm just putting you in the spot and I'm saying it's very well controlled. Everything is fine. There's no traction. You've given a number of, let's say, aflibercept injections. Patient's macula is not moving, and in fact, it's worsening. And
I'll try a steroid.
I'm saying you've tried all the, you've done that too. I'm just putting in the spot. You put the steroids, you put two steroids after 3 months, and you've done everything. So I'm just saying, is there any situation where you would go in? Because one thing, yes, we lose the reservoir of the vitreous. One thing I just like to put forth to yourself, Dr. Ajay can also respond. Role for what Yasuo Tano used to do, a non-vitrectomized, just a minimal core kind of thing, go in, pick up the thing, leave a bit of a cuff like we do for bad end of case, a large cup, so that there is some reservoir where anti-VEGF.
I would go the other way. I would do a proper vitrectomy and a macular sparing ILMP. And the only thing is, yes, a macular sparing ILMP. But before I go in, I need to see the OCT, and the ELM and the ISOS junction in the foveal area has to be intact.
Yeah, given that it is good.
Not so, I will not go in.
No, we have also seen that, with the ELM is that macular edema also with repetitive injection, it can restore, it can repair itself. Macula holes,
yes,
totally detached things come back together.
Yes, so I can show you.
As long as there's no scarring.
Yes.
That's fine. So I'm just saying, So, in those
So
situations,
I would not go in if I find that there is no ISOS junction in that area at all.
Okay.
Then I would not go.
I think I would agree with Dr. Talwar that I would look at the visual potential of the patient.
Yeah.
And if at 624, if I'm not looking at more than 624, let me leave it alone.
Okay.
But if there's some other reason, then yes, maybe. But in an attached posterior hyaloid without traction, yes. But if there's already a PVD, I don't think I stand to gain anything.
Okay.
So here, Anand, can I just?
Yeah, please, Dr. Ajay, I was about to call you on.
That patient which you presented who had thalassemia.
Yeah.
It was very clear that there was no way of getting a hemoglobin up beyond a point. So at that point, we were not able to really look at the ISOS junction so much in detail. We did have the SPOCT, but probably not aware to that extent. So at that point for me, and there was no PVD. So at that point, for me, and the patient after surgery did improve. We didn't do any ILMP, and since then the patient has not required an intravitreal injection.
No, yeah, that is the impressive part about it.
So that is something important.
Absolutely.
That on one side we keep saying that we have to keep giving injections left, right, and center, when we know that once we take out the vitreous, the oxygenation in the macula doesn't. And if it does improve and the patient is better, and now that we have such good techniques for vitrectomy available that the complication rate is really low, we don't think.
So Dr. Ajay, for you, vitrectomy for refractory diabetic macular edema is the real thing. You do it. You continue to do it nowadays also in this era.
Not really. If the patient is in situations like this, the patient has other complicating factors which I cannot handle. Yeah. I have done everything from all the anti-VEGFs, all categories of anti-VEGF and steroids. I have additional things in my armamentarium of retinopathy. I have considered that in case it looks like the biomarkers indicate that it may respond to steroid. In such situation, the endpoint thing is I would consider the vitrectomy. Though many people are saying that vitrectomy should be done earlier than later.
Yeah, no, I think the one point I'd like to just say to keep in mind. See, we know that vitrectomy for refractory DME can cause an improvement in around 45% of cases. But we also know that 25% of patients can lose vision. That is the downside of that. So it's not something to be taken very lightly. It's a scary situation. So only if that's why I said that unless I think that there's a significant potential for improvement, I agree with Guna on that. The way I would assess that potential is by looking at the OCT at the photoreceptor layers. So there I know that if this edema goes down, the chances are the vision will improve. Yeah. Otherwise, I wouldn't like to take that chance. This is one aspect of it.
I'd also like to add that perhaps we not just structural OCT, but perhaps autofluorescence also, maybe even octet to look if the capillaries is okay and healthy, and the RP is good. So that is a real situation.
A limited role.
Yeah, limited role, definitely. Just because this is one
and
little question mark.
And the presence of a posterior hyaloid detachment. If it's already detached, maybe there's not much.
Correct. So another question that pops up is, again, a kind of refractory DME with a lot, you've again done the whole gamut, whole hog of injections and steroids and everything. And one option is, though you do a fluorescein angiogram and you find it's a severe NPDR with a lot of ischemia in the periphery. And you know that perhaps this ischemic areas are driving the VEGF and causing that. So is there a role in your practice for targeted retinal photocoagulation?
I don't target
those areas.
I don't target it like that. What I do is I will do a PRP which starts around 2 disc diameter away from the arcades.
Okay.
So I don't want to touch the central fields. So I will start 2 disc diameter away from the arcades and complete the PRP up to the aura. The aura destruction causes no harm. It can only help you. And if you don't go into the arcade, your 30-degree field is absolutely affected. Okay. So therefore, if you do this, you can get the advantages of the PRP as well as stay away from the negatives.
Dr. Munna, your take on that? You have wide field angiography with you, and you know exactly which areas are leaking that VEGF. Would you be tempted to do this? Would you be inclined to consider this option?
I would, if I see significant ischemia and if I've done a fluorescein angiogram, that I would prefer to treat only the ischemic areas.
I think that is
Yes.
given the fact that now we have these wide field angiographic tools, I think that's a great thing. When we have wide field octa, that might become even more real thing. So yeah, exactly. So thank you so much, everybody. We are exactly bang on time, 4:55. I'd like to thank everybody. I'd like to thank Dr. Mona for taking all those questions, giving us such erudite, insightful answers. Dr. Dinesh Talwar, Dr. Ajay Arora, Dr. Rupak for sharing these wonderful cases at fairly short notice, as I understand, and putting up these great thought-provoking situations and sharing your experiences and your thoughts on diabetes management. Thank you so much. I'd also like to thank Novartis for facilitating this. Thank you, everybody. I had a great sad time.
And thanks to
Thank you
Anand
all.
for
Thank you.
moderating it so well.
Take care, everybody.
Thank you.
This is fantastic. First part was awesome.
Thank you. We need to have more of those interfaces.
Yes.
So thank you very much. We leave the forum now for the next session. Thank you.